Good morning. I'm Dr. Jeff Eggart. I'm a clinical lipid specialist, and I'd like to talk with you about heart disease and what you can do to prevent heart disease and protect your family. Particularly, we're going to talk about atherosclerosis and cholesterol plaque formation. And the first thing I want to tell you about heart disease is this. There's no such thing as a sudden heart attack. Atherosclerosis has been present for 15 or 20 years prior to an event. We have new technologies which can detect disease at an early age, and it's very important that we do this. And you see, this is why. There are about 700,000 heart attacks each year. And what we know is, for men, for example, about 60% of men with heart disease, the very first presentation, the first sign of problems, will be a heart attack or sudden death. And for those patients who have a heart attack, a third will not survive for 24 to 48 hours. So we really must find this disease at an earlier stage where we can interrupt the process before it causes these terrible consequences. Now, often what patients will say to me is something that goes like this. Well, I take a statin, so I must be safe, or I'm fine. Well, just how much protection do you get when you take a statin drug? And what we see here from one of the very, very large statin trials, they looked at patients who took statins. In this case, it was simvastatin. You may have known it as Zocor. And what you see here is there was a reduction in deaths. About 181 events were prevented, or a 30% reduction in heart disease for those patients who took a statin. Well, that's a problem because you're only preventing 30% of the events. And I thought about that and tried to put it in perspective for you, and it just came to my mind about the passengers who got on the Titanic. And you know, when they did this, we know from history that there were about 2,200 passengers, 706 survivors. So really, what are the odds that Leonardo DiCaprio, when he gets on the boat in England, headed for America, would make it? And actually only 31.7% of the customers would make it to America. That's DiCaprio's odds. It's about the same odds you have if you're taking a statin to prevent heart disease. Oftentimes you'll need to do much more to correct all the problems which lead to vascular disease. Now, so when you look at these statins, what you see is, we see that while there's a reduction in heart disease, we need to do much more. We're only going to get 30% event reduction, and 70% of the time we're going to fail to prevent further events. And today I want to talk with you about how that plaque forms, how we can stop the process. So the next thing I'd like to talk with you about is something else that I often hear. A patient will say, I had a stress test, I had an exam, doctor said I was doing great. Well, it always brings to mind the experience that President Clinton had. Each year he would have a thorough exam, and he had modest elevations in his cholesterol, you can see that here, and his fasting blood sugar was slightly elevated, a little that metabolic type syndrome, a little extra weight, and he had a stress EKG. Each year these examinations were normal. I want you to focus on this particularly. His stress EKG. He got on a treadmill. He had several of them. The last one in 1999, the cardiologist wrote, "Great job, Mr. President." Many of you have had a stress test. You might have some experience with friends who've had a stress test, and yet just a few years later they had a coronary event. Well, here's President Clinton's results on his heart catheterization just about 3 or 4 years later, and he has multiple blockages, and he undergoes a coronary artery bypass graft. Is there some technology that we could have better detected the disease and intervened? And there is a lot of new technology, and we're going to look at some of those today. Now, one of the things you need to understand about stress test, a treadmill stress test, this is a wonderful test. It's done a lot of good for many, many people. But you need to understand its limitations, just how sensitive it is. So if you have blockage in your heart, how much blockage do you have to have before the test will be abnormal? And what you're seeing here are a series of different illustrations showing varying amounts of blockage. This would be a coronary artery with about 90% blockage, and you can see that here, or 70% blockage, or 60%, or 45%. Now if you have a major coronary artery that has 70, 80, 90% blockage, and you get on a treadmill and exercise, you may have some symptoms. Most people will have some chest pain, perhaps shortness of breath. However, some patients don't have any symptoms, and this is particularly true in women and in diabetics. And if you have a treadmill stress test, and you're like this, with a high degree of blockage here, the test will usually be abnormal. On the other hand, if it's more like this with a 60 or 70% blockage, that test will be read as normal. And unfortunately, what we know now is that most heart attacks are caused by a rupture of relatively small plaques, and these would be missed on a treadmill stress test. So we really need to understand more about how plaque forms and how we can find it at an earlier stage. Now, this is a process of atherosclerosis. The first thing you should know is that cholesterol is a type of fat. In your body, you use it to make hormones like estrogen and testosterone. You use it to form the walls of cells and to form bile. About 80% of all the cholesterol in your body you make yourself. Only 20% comes from your diet. So you can have a very good diet and yet nevertheless have quite elevated levels of cholesterol. Now, the cholesterol from your liver is carried throughout your body in lipoproteins. You can imagine these as delivery trucks, a huge fleet of UPS trucks loaded with cheese driving up I-95. And those particles carrying cholesterol flow through your arteries just like this. The LDL particles particularly can go into the wall of a blood vessel. They pass right through this little white lining that you see here, and they go into the wall, and then this yellow cheesy cholesterol plaque accumulates over time. In this frame, there's hardly any room left for blood to flow. If that was an artery in your heart, you'd probably have some symptoms. Now here, in the bottom of the picture, these are actual blood vessels. And what you see here is the gray is blood flow. The small circle is an ultrasound catheter. It's taking the picture. This crescent shape along here is plaque, more cholesterol plaque, a tremendous amount of cholesterol plaque. If you're like this, classically you'd have symptoms of pain whenever you exercise or angina. The other thing that's important to notice here is what happens in this frame. And what you see here is this particular plaque is inflamed and it ruptures. And when that occurs, over the next few minutes, your body would form a blood clot here in the middle of the artery. And that blood clot would suddenly obstruct the blood flow. It would be as if a tractor-trailer rig flipped over and blocked all 6 lanes on I-95. It'd be a catastrophe. You can see a picture of a plaque rupture here. You see the small rupture within the blood vessel wall. This is what actually causes a heart attack. And if this was in your brain, it would be a stroke. Now, I want you to notice this too. Before that plaque ruptured, the day prior, there was adequate room for blood to flow. So the day before this occurred, that patient could get on a treadmill or go to the gym and really wouldn't have any symptoms. We know that most of the plaques which rupture and cause heart attacks tend to be these smaller plaques. And when we think about the formation of these plaques, the most important factor are the number of particles flowing through the artery that carry cholesterol, and then there are other factors which damage the lining of blood vessels: hypertension, high blood pressure, elevations in blood sugar, diabetes, nicotine, cigarette use. Diet also impacts the health of this blood vessel wall. And as the disease progresses, we see this thickening in the wall here. This can be detected with an ultrasound examination in the carotid system, or as plaque begins to form and the disease is more advanced, calcium will form within the plaques, and we can see that on a cardiac calcium scoring. Later disease here can be detected with a stress test or a nuclear test, or certainly with a heart catheterization. Now when you look at a plaque, this would be where blood flows. This is the cholesterol plaque here, and there's a thin green cap right here, the fibrous cap that protects it from rupture. When there's a lot of inflammation here in the blood vessel wall, there are enzymes created which destroy this cap and lead to the rupture. It looks like this. Here's an actual artery. This is where blood was flowing. This is the cholesterol plaque here. This is the point where the plaque ruptured. Now what we need to understand is, how did that cholesterol get into the wall of the blood vessel? Well, that's because of the particles that flow here in the middle of the blood vessel through the lumen. Just as if we thought of them as trucks driving on I-95 loaded with cheddar cheese, you might begin to consider that there are different types of trucks driving on the interstate. And there are different types of particles that carry cholesterol. We also worry about where plaque rupture occurs. This is an artery from the heart. The plaque was here. This is where it ruptured. The dark structure is a blood clot obstructing the lumen, the part where blood would normally flow. And this plaque rupture killed that person. Now the consequences of the rupture also depend upon where it occurs. When you look at the heart, you can see it here. The left side of the heart pumps to your entire body, has a lot of work to do. The right side pumps to your lungs. The right coronary artery here supplies that side, and then we see these main branches here on the left side. If a plaque rupture occurred right here, it blocks this blood flow. However, we can get some blood flow coming here from these collateral vessels. It would be sort of as if you had a sprinkler system in your yard and it was out. And along the property line you had shrubbery and trees. Well, you get some water from your neighbor's sprinkler system. It's also important where in this major vessel. And this is the left anterior descending. If a plaque rupture occurred here, you'd see it be a smaller area with lack of perfusion. If it was at the beginning of the left anterior descending, that'd be a much worse state. Another thing that can occur, it might occur here in the left main artery. Well, if a plaque rupture occurred here, it would block not only this artery, but also that artery. That would be a catastrophe. This would be as if not only your sprinkler system is out at your house, but both of your neighbors are out. So you see, we want to know where plaques are with a rupture, and the size of the plaque, and also the location is very important. Now, how did the plaque get there within the wall? That depends upon particles. And just as if there are different types of trucks driving down the highway, like UPS, FedEx, and Emory, we have different lipoproteins carrying cholesterol. HDL lipoproteins, LDL or low density lipoproteins, and VLDL lipoproteins. Now, they all have some cholesterol. These particles, HDL, are usually referred to as good cholesterol. And in fact, they can remove some cholesterol from the wall of the blood vessel. They really do much more than that. They carry a number of proteins which reduce inflammation and oxidation in the blood vessel wall. They reduce thrombosis. So these particles are very, very important. If you're deficient in HDL particles, then we'll see plaque formation, and often we'll see early heart disease and stroke. These LDL particles are the most dangerous. When patients refer to the low density lipoprotein or bad cholesterol, they're referring to these particles. When they go through the blood vessel wall, through the lining, they undergo oxidation and they're trapped within the wall and contribute to plaque formation. The statin drugs like Lipid, Zocor, Pravastatin, they reduce LDL cholesterol. Now, these large particles here, VLDL, are released by the liver. They contain two types of fats, or lipids if you will. Cholesterol, to make hormones and build cell walls, and a second fat we call triglycerides. Triglycerides are fats we use for energy, and that's principally what's in these particles. So usually you'll hear physicians refer to your triglyceride levels rather than your VLDL triglyceride. But I want you to keep in mind this also. There is some cholesterol in these particles, and if they're excessive, they can contribute to plaque formation. So people can form cholesterol plaque because they have too many of these particles, too many of these particles, and not enough of these particles. Now this raises the question, what's a good profile? And if we look across the world, we can see entire populations of humans that never have heart disease or stroke. For example, these are the particles that particularly will cause plaque formation, and you'll sometimes hear them referred to as the ApoB particles. These are all the bad ones together. So what's a good profile? Where am I safe? This is one of those groups of humans that don't have heart disease. These are the Bushmen that live in the Kalahari. Each day they walk about 6 to 10 miles hunting antelope. The only thing they have to eat are some nuts which they carry here. They store water in ostrich eggs, and after 2 or 3 days they will run down the slowest antelope till it's exhausted and can run no further, and then they'll kill it with a bow and arrow or a spear, roast it, eat it, and get up and do it all again. If you would draw a blood sample in the Bushmen of the Kalahari, this is what their total cholesterol will look like, about 120. If you look at the LDL cholesterol, the cholesterol within those LDL particles, the most dangerous ones, it's about 50 to 75. If you drew a LDL cholesterol level in a 4-month-old infant in the United States, it's usually about 40. Now, if we think about other creatures in the animal kingdom, an African elephant has a total cholesterol about 115. If we look at primates, baboons, about 115, and then the Bushmen here, and other human gatherer groups, the pygmies in the jungle, the Inuit in Greenland. And what you see is all of these humans that hunt and gather their food, that don't have heart disease or stroke, have a total cholesterol between about 110 and about 130, just like all the other animals on the earth. Now the typical person in my office, typical American, has a total cholesterol of about 208 out here. And we tell them that they're normal. But are they really? We see patients with 200 cholesterols, total cholesterols, that have heart attacks all the time. Now, one of the things we do here is we're looking at the LDL cholesterol, that subfraction, and the likelihood a person would go to the hospital with a heart attack. And what you're seeing on the graph is, as LDL cholesterol increases, the likelihood a person goes to the hospital with a heart attack increases. The Bushmen in the Kalahari, who don't have heart attacks, are down here at around 50 to 70. Usually if a patient has already had a heart attack, or if we know they have advanced atherosclerosis, plaque in their carotid system, or we know that it's in their coronary system, we'll want to reduce the LDL cholesterol down to these much safer levels. Now, one of the things that we know about heart disease and cholesterol, most of it was derived from the study known as the Framingham, Massachusetts study. You may want to Google that. And when we look at cholesterol, patients will say something that goes like this: the doc says my cholesterol's fine. Well, cholesterol is certainly important, but it's very difficult to predict just from the cholesterol alone who will have a heart attack. And we can graph it, and what you see here, this graph is of people who have coronary heart disease, and this graph is of people who do not have coronary heart disease. And what you see is they overlap tremendously. Now, if your total cholesterol is very low, below 150, you're extraordinarily unlikely to ever have a heart attack. And if your cholesterol, your total, is above 300, you virtually are assured of having a heart attack. The dilemma is almost all the patients we see are in the middle. And just looking at cholesterol, we really don't know if they're going to have heart disease just from the total cholesterol alone. So we have to do more. And also, what we must think about is, you see what determines the plaque formation. The most important factor are the number of particles that carry cholesterol in your blood vessel. When you tell me your cholesterol, you're giving me an idea of the number of particles. It would be just as if I said to you, how many trucks are driving on I-95? And you said, well, UPS says they're shipping 1 million tons of freight today. Most days they only ship 500,000 tons. So today 1 million. There must be a lot of trucks on I-95. And you're probably right. The dilemma is this. UPS has different size trucks. Large, small, medium. It may be they kept all the small trucks at home today and there aren't very many trucks on the road. The particles in your bloodstream, the lipoproteins, are much the same way. You could have lots of small particles, like this person, or you could have very few particles, but they're quite large, like big Walmart vans. And yet, both patients would have the same cholesterol values. You see, what we really want to know is the number of particles in your bloodstream. That was very difficult to measure until fairly recently. One of the ways we could do it is like this. Suppose I told you that we had a way of counting license plates on the trucks as they drive down the highway. Well, it just so happens that there's a molecule that's on the lipoproteins, LDL and VLDL, and that molecule is called apolipoprotein B. You can see one here on the surface of that lipoprotein. There's one apolipoprotein on each one of these particles, like a license plate on a truck. We can count it very easily. So one of the ways we could count the particles in your bloodstream that cause plaque formation is to count apolipoprotein B. There's another method too. You see, here's the ApoB particles, the ones that cause plaque formation. And we know at what levels patients will form plaque. We can measure that to determine, are you at a safe place? Now there's another way we could count the number of particles in your bloodstream. Another way of counting the number of trucks on the highway, if you will. And what I'd like you to do is imagine a large MRI machine. Most of you have seen pictures of an MRI that have been taken with an MRI. Well, if that MRI machine was on the interstate, and suppose every vehicle had to pass through it, it would measure exactly how large the truck is and would count it. Well, we can use the same technology to count and measure these particles. This is how we do it. The first thing I wanted you to know is, initially, back in the 40s, this man named Goffman, who worked at the Lawrence Berkeley nuclear lab, and he was isolating different isotopes of uranium and plutonium to make the atom bomb. Soon after the war, he changed his field of interest to medicine, and he began to isolate the particles in the bloodstream. He would do this by ultracentrifugation. That's why we call them low-density lipoprotein, high-density lipoprotein, and VLDL. That's Goffman. The dilemma with it, measuring the particles like that, is that it takes all day. It's very difficult to do. So what physicians did was, we would estimate the particles by counting the cholesterol within the particles, or the triglycerides. You know, like telling me how much freight UPS is shipping. And we knew there were limits to that technology, and we see problems with it. Well, there's a newer technology that we could use, and it depends upon this man. His name is Otvos. He was at the Lawrence Berkeley lab also, and he wanted to identify those particles using magnetic resonance technology, nuclear magnetic resonance technology, in which the samples are placed in a large set of magnets. They're then radiated with radio frequency waves, and they emit a signal. And that lets us identify the number and the size of these particles. It looks like this. This is the signal. It then undergoes a lot of mathematical processing where we can determine the number of particles and their size in a person's bloodstream. And we get a graph like this. This is a typical patient. The green are the HDL particles. And what we see here is this patient has a lot of very small HDL particles and only a few large ones. These are their LDL particles. And again, this patient has primarily the little small particles, like small pickup trucks, many of them driving down the highway. And these VLDL particles, and these are the ones with triglycerides and cholesterol, he's got a lot of these. This is an NMR, nuclear magnetic resonance graphic representation. It also can count the particles. See, here's a larger illustration of a graph. And you see, for example, in this patient, the number of LDL particles is 1,534, the number of trucks on the highway, if you will. Well, if that patient has heart disease, we know that after a value of about 1,000, they'll begin to form plaque. So we need to reduce those particles to a much lower level to make it safer for that patient. This is a liposcience nuclear magnetic resonance lipid analysis, a very helpful test. Something else it does for me is this. It helps me to know what therapy would be best. If I have excessive numbers of LDL particles, I can lower that with a stronger statin, or I can use an additional drug which blocks the absorption of cholesterol. You may have known that as the drug Zetia. On the other hand, if I have excessive numbers of VLDL particles and triglycerides, well, I'll use a different therapy for that. So, here's the fundamental question when I see a patient who's had a heart attack, or they've had evidence of progression of disease, or they want to do everything they can to avoid a heart attack. This is the first question. Are you making plaque? And we know that if the number of those ApoB particles exceeds 80, most patients are making plaque. So we'll want to reduce it to a lower level. Or we can measure the number of particles in the most sophisticated manner with nuclear magnetic resonance, LDL particle numbers. When they exceed 1,000, usually patients are making plaque. Another way we can estimate if plaque is continuing to form is to use estimates, an LDL cholesterol level and an HDL cholesterol level, and look at this ratio. When it exceeds a value of 2, most patients will continue to form plaque. So, the next question we're going to have, and we'll talk about this in the next video, is this. How much plaque has a patient already made? How do we measure the disease in the early stage? And we're going to talk about 2 new technologies, carotid ultrasound to measure disease in the carotid system, and coronary artery calcium scoring to measure the amount of plaque in the coronary arteries and determine the essential locations within the various arteries. Well, this is Dr. Eggart. I hope you were able to follow this lecture today, and it's very important that you do your best to reduce all of your cardiovascular risk factors. We'll have some additional videos covering such subjects as how to reduce triglycerides, VLDL, and again studies to illustrate to you how these newer technologies are used to protect you. Thank you.